Hi, and thank you for joining our educational webinar with Dr. Robert Larson and Daniel Newton on the importance of early detection in managing aortic disease. My name is Morgan Hamlin, and I'm a member of VCU Health's marketing team. Before we begin our presentation, I would like to first make note that we will hold all questions until the end. Please feel free to drop any questions in the comment section, and we will address them at the end of the presentation. Dr. Larson is a vascular surgeon at VCU Health and an associate professor of surgery at VCU Medical Center. He attended medical school and completed his internship, residency, and fellowship at the University of Pennsylvania Health System. Dr. Newton, a native of Richmond, is a vascular surgeon. He attended VCU's School of Medicine and completed his internship and residency there. In addition to caring for vascular surgery patients, he also serves as the Associate Program Director for the Vascular Surgery Fellowship. Thank you, Dr. Larson and Dr. Newton, for joining us today. I will now turn the show over to you.
Well, great. Thank you. It's wonderful to be here, and I hope we can answer some questions and tell you a little bit about what we do in our world as vascular surgeons. So next slide. So this is a common question. What is vascular surgery? We don't have the high profile of some of our colleagues, like cardiologists and heart surgeons, but what we do is pretty basic because next slide, the body's full of blood vessels, and lots of problems can happen in blood vessels all over the body, and that's where we work. Next, and so in a sense, it's kind of high-tech plumbing, and the things that we deal with are the problems that a pipe might have in the body that can become clogged, it can become broken or damaged in various ways. And next slide. The main reason that blood vessels have a problem that we deal with is because of a disease called atherosclerosis, or hardening of the arteries. And this is a disease which builds up over long periods of time in most patients. It culminates in heart disease, and it causes heart attacks. It can cause strokes, but it causes damage to blood vessels, again, all over the body. What we are going to talk about today are, next slide, the impact of that disease on the aorta. And the aorta is the biggest blood vessel in the body. It's the main highway. It's the high pressure line through which the blood flows out of the heart and to the rest of the body to be distributed. One of the problems that can happen with a aorta is it can develop an aneurysm. Now, an aneurysm is just a fancy way of saying a blood vessel or structure that it gets too big. And it's because of the atherosclerosis that the artery becomes weakened, and under blood pressure, it stretches out and becomes an aneurysm. It's a pretty common problem. There are a couple 100,000 diagnoses each year, and people still die from this, even with all the technology and medical surveillance that a lot of people have. Most of these are asymptomatic, especially when they're small, and they generally don't become a problem noticed by the patient until they rupture or burst, and that's when it can become fatal. It happens in everybody, but there is a predominance in men. Next slide. So where does it come from? Well, it's the same process that causes heart disease, and we all know these things, and these are the factors that our primary care doctors are telling us to deal with. And the biggest one of all is smoking. Smoking actually has a stronger effect on the aorta and aneurysm formation than it does in a lot of other areas in the body. It sure can affect the lungs directly, but it's like acid that eats away at the structure of the artery. Next, high cholesterol. People with high cholesterol develop plaque, and it leads to heart attacks. But that plaque and the inflammation and the reactions to it also help weaken the artery. Next, diabetes is a factor. I think more associated with making blockages in blood vessels, but it certainly can cause problems in the aorta as well. Next, and high blood pressure. The aorta is a pipe, and if you put too much pressure in the pipe, it can have a problem. This is something that leads to one of the other problems that can happen in the aorta, a dissection, which Dr. Newton will talk about. And there is a family connection when it comes to aneurysms. If you have a close relative, especially on your mother's side, who has had an aneurysm, then you may be at an increased risk for that. Next. So what do you do about it? Well, these slides are pretty self-evident. It's just stop smoking, control your cholesterol, which is your next slide. Control your hypertension, and that's exercise. Sometimes it takes medications. That's fine. Getting the blood pressure under control. Next slide. Controlling the cholesterol, eating well. Sometimes eating, if you can, if you need a statin medication to help control the cholesterol, that is very helpful. And managing diabetes, and that means keeping your blood sugar under control, diet, exercise. And these are the basic things. I think that as you get older, all of these problems become more prevalent. And these are kind of the focus of your day-to-day health with your primary care provider, but they also are very good for your blood vessels. Next. So how do you diagnose it? Well, I mentioned that most of these are asymptomatic, so patients don't know they have them. Most of them nowadays, many at least, are diagnosed incidentally. And that means by getting a scan for some other reason. It's uncommon to go to the emergency room these days without getting something scanned. So if you get a CAT scan or an MRI or an ultrasound of your abdomen, if there's something there, it actually could be identified. And that's how many of these come to our attention. You may be identified on routine physical exam. If your family doctor kind of presses on your abdomen and listens around there, they may be looking for a pulse, a stronger pulse than expected, and that could be a hint. And once there's a suggestion that there is an aneurysm, we'll generally start in terms of diagnosing it with an ultrasound, but sometimes a CAT scan gives us a better picture of it. But what we need to identify where the aneurysm is and how big it is. Next, please. So again, most of them don't have symptoms. In someone who's fairly skinny, if you press on the abdomen, you may feel a strong pulsation. If you press deep enough in anybody, you're going to feel a pulse. But and knowing what's enough and what's not enough can be a little challenging. But if you can feel sometimes you can feel the aneurysm in a skinny patient. And obviously, the worst case scenario is when an aneurysm ruptures. That's the biggest blood vessel in the body. It ruptures. It causes bleeding into the abdomen and into the areas around the abdomen. And that creates a great deal of stretching, which creates a lot of pain. So sudden onset of abdominal back pain, it'd be something that's different from than anybody had ever experienced. It's not like normal back pain. And if this is associated especially with loss of consciousness or low blood pressure, that's very suggestive of an aneurysm in a patient of the right age group. Next slide, please. So what can you do to get ahead of this? Well, there are aneurysm screening programs. Next, particularly, there's the SAVE Act of 2007, and this law was put into place to help reduce the incidence of aneurysm ruptures. And so when a patient is transferring to Medicare from their former insurance, as part of as part of your welcome to Medicare package, any man who has smoked or any man or woman with a history of a family history of aneurysm can get a one-time screening ultrasound. And if it's negative and you're 65, the chance that you're going to get an aneurysm down the road is pretty small. So that one screening aneurysm would pretty much close the door on it. There are also screening events that may happen through various medical institutions. Those can be helpful too. They can do a one-time aneurysm screen. But any screening that shows an aneurysm is not definitive. It would need to be followed up with a better study to really get a good picture of what's going on. Next, please. So if you got a diagnosis of an aneurysm, whether it's on a screening or from your family physician, what do you do? Well, you come to see one of us. We're a vascular surgeon, and because we're the group of physicians who manage these problems. A lot of it comes down to patient education about what the aneurysm is all about. It's a pretty frightening thing when you hear the word aneurysm. So we try to put it into perspective as to where it stands on the spectrum of severity. Medical management is key, and that gets back to the things we talked about a moment ago, stopping smoking and being on the right medications to control the medical factors. Fortunately, most aneurysms that are found are fairly small, and if they're small, they're not really dangerous. We just want to make sure they don't get any bigger. And so we will watch them periodically over time with an ultrasound to gauge its growth if it has any. When they do become big enough and they become a worrisome thing, we obviously want to fix it before it has a chance to rupture. A ruptured aneurysm is an emergency, and the risk of dying is pretty high. So if an aneurysm is fixed beforehand, that can be controlled pretty well. Next, please. So an aneurysm rupture, again, it's like a balloon. You blow up a balloon too much, it'll pop. It's the same idea, and it creates a lot of bleeding inside the abdomen, as you can imagine. Next slide. So the standard way of fixing this is a pretty big operation. It's an open surgical repair, incision in the abdomen, going down through around all the intestines, and the aorta is way in the back. And you can think of it as a broken pipe. And what we have to do is replace that section of broken pipe. Given its nature, it's a pretty big operation, but it does really well. It was first done in the 1950s, and this technique has been optimized ever since, and patients do well with it. It's just a big operation, and the recovery time from it is on par with other large operations. But again, technology offers a lot of answers and can solve a lot of these problems for us. Next, please. And again, this is just another picture of an open repair, putting in a new graft, a new artificial pipe to replace the part that was broken. Next, please. So what has happened, and actually a couple of days ago was the 30th anniversary of the invention of this technology by a famous vascular surgeon named Juan Perotti in South America, who came up with the idea that instead of going in through an incision, getting down to the abdomen and replacing the broken pipe, why can't we just put a new pipe inside of the old pipe, repair it from the inside, which is much less invasive. We don't need to move anything around in the abdomen to do that. And this is called an endovascular repair. Endovascular just means inside the blood vessel. And so using X-ray guidance and catheters and wires and the kind of tools that you would think of if you know anybody has ever had a heart catheterization. It's the same idea, a little more scaled up. The blood vessel's bigger, but it's the same idea. Next, please. So in order to do this, we have to use X-ray guidance, and this is a picture of what's called an aortogram, or a picture of the blood vessel. You can see the aneurysm kind of bulging out there, and the thing with the aorta is there's lots of blood vessels coming off of it. Its job is to distribute blood across the body. So we have to be able to fit the new pipe inside the old pipe, but still preserve the blood flow to other vessels. Next, please. And so to get there, we don't have to make an incision in the abdomen. We actually, most of the time, do a percutaneous, just a puncture in the blood vessels in the top of the thigh on the right and left side. So there's not much from the outside that the patient has to heal from. All the work we do on the inside, patient doesn't really notice that. It's just the puncture sites, which are something that heals pretty quickly. Next, please. And so it's this is just a comparison of kind of the endovascular, intravascular, inside the vessel repair, where we're putting a new pipe inside of the old pipe, and the open repair, where we have to actually replace the section that's broken. The end result is quite similar, because you're putting strength. You're actually putting in a new piece to replace that part that has been dilated. Next, please. So obviously, less invasive procedures. Patients do a little bit better overall. It's a shorter hospital stay, less blood loss. It puts less stress on the heart and lungs. Patients are back to their normal activity a little more quickly. It's still an operation. It still takes for most patients general anesthesia. For patients who are less fit, let's say they have a bad COPD, it can be done under local or regional anesthesia, but most of the time it's general. And so there's something to recover from, but it's definitely in a different class than the large open procedures. Next, please. And so the tools that we use are similar to what a cardiologist or what we actually use in other areas of the body, stents and balloons and wires. But most importantly, next slide, and this is what one of the various different types of grafts look like. And this is the new pipe, again, that we put inside of the old pipe. Next, please. But this is one of the key elements that allows us to do this. It's the endovascular hybrid operating room, where we have a high quality X-ray imaging machine that allows us and guides us as we put these devices into position. And putting them together is kind of like building a ship in a bottle. And it's all done over these wires and catheters using the X-ray guidance. And this room is what allows us to do it with extreme precision. Next, please. We'll see if this works here. So this is just a little cartoon. It's kind of I think my last slide here, but it gives you a little idea of what I've been talking about. That's an aorta, and this is a sheath being placed inside of the aorta. The sheath contains this new pipe, and when you deploy it, it springs into position. And so each half is done by itself, and you can see how we're building this graft inside. And all these grafts are sized to the patient's anatomy. So they're customized to the size and the shape of the patient's arteries. And so a little balloon to touch it up, and that's in place. So obviously just a cartoon, but it really does represent the major steps in how we do this. So I think that's what I have to say. And so let me see, I think next slide is probably Dr. Newton coming up. Yeah, so we'll have plenty of time for questions, but that's kind of a brief overview of sort of how we get to aortic problems and the problem of aortic aneurysms, which is a big one. So at this point, I'll give it to my partner, Dr. Newton, to talk about the other side of the aortic issue.
Great, thanks, Bob. So one of the reasons why we're doing this is that Aortic Disease Awareness Week is coming up. It's the 19th to the 26th. You might recognize some of these faces: Lucille Ball, Alan Thicke, and John Ritter. And all three of these folks unfortunately passed away because of the aortic disease. And our hope here is today that we can maybe raise some awareness and potentially prevent future death. Next slide. So where is the aorta in the chest? Well, you can see the heart kind of right in the middle of it, and that red pipe coming around is the aorta. It goes up, and the first part of it we call the ascending aorta as it heads up. The arch is where it takes a turn, giving off branches to the head and the arms. And the descending aorta, obviously descends down into the chest and then into the abdomen. Next slide. There are really two primary aortic diseases that we're going to sort of touch on today. Bob mentioned atherosclerosis as a cause. In the chest, atherosclerosis can be a cause of aortic problems as well. There can be just sort of genetic factors and other biomechanical issues. So aortic aneurysms are one. It's a ballooning of the aorta, as Bob mentioned, and we can see that on the left. On the right, and this is a sort of disease that attacks the aorta in the chest most primarily, is aortic dissection, and that's a partial tear in the wall of the aorta. It lets blood go between the layers, and that causes this flap in the middle. Next slide. Aortic aneurysms, as Bob mentioned, are usually asymptomatic at first until they get so big that they cause stretching or even rupture. Aortic dissections, on the other hand, because it's a tear, is usually quite painful. It's usually described as a sudden onset type chest pain and back pain, and it's a medical emergency. Next slide. The risk factors: smoking, family history for aneurysms. For aortic dissection, genetics tends to play a little bit bigger role, as does a condition called bicuspid aortic valve, which is an abnormality in the aortic valve. The Aortic aneurysm, can rupture or lead to dissection. The aortic dissection can cause a blockage in blood flow to the vital organs, or itself can rupture because the wall is weakened. Next slide. So where can aortic aneurysms happen? It can happen in the ascending aorta, the top part. Next slide. The descending thoracic aorta. Next, and then in the abdomen, as we talked about earlier. Next slide. Dissections can similarly happen kind of anywhere, but there's sort of primarily two places. One is at the very start of the aorta as it comes out of the heart, called the aortic root. And then the other is just where it starts to take a turn and head down the chest. And where a dissection matters, where the dissection matters quite a bit as far as prognosis and how it's treated. With the aortic section, the type A aortic section comes off right at the aortic root, being a bit more serious. Next question, next slide. There are a couple of different methods to treat this. One is observation and just medical treatment. Typically, small aneurysms and stable dissections are low risk, and often just watching them carefully and good medical therapy is the safest option. It's usually going to be a yearly appointment, maybe a little bit more frequent in the very beginning, and we're just going to keep an eye on it and make sure the blood pressure is well controlled. Stenting is a minimally invasive option to treat these two diseases. It does require lifelong follow-up and sometimes requires more than one procedure to get everything fixed. Then, of course, open surgery. That's sometimes necessary for more complex problems. As even though stenting's come a long way, it's still sometimes necessary. As for the timing, sometimes it's really an emergency and the treatment needs to happen right away, including surgery. That will depend on the symptoms that the patient's experiencing, as well as the location of the tear in the case of a dissection. However, it's often not urgent, and treatment may occur in weeks to months out, or again, maybe just medical therapy and observation is the best course. For medical treatment, the mainstay is blood pressure management. So what we're trying to do is take the pulse, which is kind of like a jackhammer, we're going to slow it down and make it not as intense. We call this impulse control. Stenting is also an option. I think Bob showed some nice images of stenting in the abdomen. I just kind of wanted to show you guys a stent here. So you might be familiar with stents in the coronary arteries or in the legs, and they're pretty small, about that big. A TEVAR, a stent that goes in the thoracic aorta, is kind of like the granddaddy of stents. So that would be deployed. If we go back to the slide, you kind of carefully position it and deploy it inside of the artery, and that will seal above and below the diseased segment of the artery, protecting that area. And in the case of dissection, oftentimes letting it heal. Next slide. Open surgery is sometimes necessary for more complex issues that involve some of the branched arteries, especially when for instance, a dissection or aneurysm is involving the ascending aorta close to the heart. In that case, a graft is sewn into place, and those branch arteries are sewn back onto the graft. Sometimes it needs to be done with under cardiopulmonary bypass, and we certainly have those capabilities here at VCU. So there are some advanced options that are becoming available as technology advances. Initially, the grafts were designed to be like the ones that we've sort of shown in the pictures, with no sort of side holes, no branches, and it totally covers up the aorta. Obviously, disease like this can affect anywhere along the aorta, as we mentioned before, and so managing dissection or aneurysms that involve those branch arteries is quite tricky with stents. Really three options are available. One is hybrid surgery, where we do an open bypass, basically around the artery that's going to end up getting blocked, and then we put a stent in that will cover up both the disease segment of artery and that side branch. As well, there are some fenestrated devices or branch devices, so basically stents that have either branches or little windows on them to allow blood flow into the branches of the artery. And then there's, in emergency situations, sometimes modification of devices that are done by the surgeon themselves. These cases require a lot of advanced planning, and here's some pictures of those types of cases that are done here at VCU. It requires pretty advanced imaging capabilities. So, we're certainly available to treat those issues as they come up. Next slide. There are really four things that are important to remember for aortic health. One is to manage your blood pressure. Two is to stop smoking. Three, know your family history. And then four, if you have a problem with the aorta, even after you're sort of seen and diagnosed with it initially, you got to make sure you're following up with an aortic specialist regularly and being your own advocate with your doctor. I think that's all. Really, thank you for the opportunity to talk to you guys today, and we're happy to take any questions that you have.
Great. Thank you both so much for that informative presentation. I know I learned a lot. We will now open the floor for any questions. We can read the questions in the comment section. If you have any, please put those there. We also have a couple questions that were submitted in advance, so I'm going to read those first. So for the first question, if I am not experiencing any symptoms, why should I consider repairing my aorta?
Well, that's a great question, because I always tell patients when we were fixing an aorta, an aneurysm before it ruptures, when it's rupturing, it's not even a question, right? My goal is to get the patient back to feeling like they are the day before surgery. So we're fixing something that's not causing a problem today, right? So the patient doesn't even know it's there. The problem is that aortic aneurysms change over time, and when they grow, they become more dangerous. Nobody can tell when it's going to rupture. We just have an idea that when it's above a certain size, the risk becomes really just too much to bear. It's about prevention. And so catching it in time is the key thing. Fixing it before it ruptures is the name of the game. But small ones, yeah, you just follow them.
Great. So our next question that was submitted is, are there any restrictions in activities now that I know I have an aneurysm?
So I'll take that one.
Mm-hmm.
The main restriction that we have is to avoid very heavy lifting. So we know that during sort of powerlifting level, the type of lifting where you have to sort of grunt or bear down, your blood pressure can really skyrocket. In fact, normal blood pressure maybe 120. If you do some squats with quite a bit of weight, you can get it up above 300 temporarily. And so that short duration of very high blood pressure can cause more stretch on your aneurysm, cause it to grow more rapidly, or even cause it to rupture. That's the main activity that we ask people to avoid. Is heavy lifting, but of course, stopping smoking. So definitely smoking.
I was going to say, if I do CrossFit, I probably shouldn't do that if I know I have an aneurysm.
If you know you have an aneurysm, yeah.
So, I mean, one thing to remember though is that aneurysms are, except for genetic variants, which exist but are fairly rare. Most patients are older, and so there's some people who can lift furniture and move things like that, but for most patients, it doesn't really require a big change in their lifestyle, because they're just not pushing it to the limits like they used to.
Right. So then our next question that we had submitted is, what are the chances I have another aneurysm somewhere else? I'm assuming if they've already had one previously.
Sure. Well, it's pretty small, and most people who have an aneurysm have been scanned in other locations. And if an area of the aorta is normal or relatively normal, it'll pretty much stay that way over the course of a person's lifetime, over the next 10, 15, maybe 20 years. Again, we're talking about patients who are maybe in their 50s at their earliest, 60s and 70s becomes a little more common. So it's possible, but one of the things we do after an aneurysm is repaired, patients are followed. So we do keep an eye on things, although the risk of a new aneurysm is on the low side.
Okay. Another question that was just submitted is, what are the symptoms of an aortic emergency?
So it depends on where the problem in the aorta is. Severe crushing chest pain, just like a heart attack, can be a sign of a problem in the aorta. As it sort of comes right out of the heart in the front. Otherwise, it's typically back pain, either upper back pain, or if it's in the the chest, or lower back pain. But it also can be abdominal pain. All these types of pain, though, are very it's not subtle. It's not I a little bit tweaked my back. It's a totally new tearing type of pain. So you'll know something's wrong. It's not subtle.
Mm-hmm.
So how much time, if someone is feeling that, how much time do they have before they need to get to receive care?
I think the honest answer is you don't have much time. You need to get call 911 and get to a hospital as soon as you can.
Okay.
There's really no sort of safe time to wait. Any sort of delay in getting to the right facility that has the capability of fixing the problem. That's got to be minimized.
Okay. And it looks like we have a question for Dr. Larson regarding a one-time test that I think you listed. If you're a male smoker, are you eligible for a one-time exam test? And does this also apply to females?
So the male smokers, definitely. Females, if there's any family history of AAA, the incidence in females is much less. And so that was brought into the decision-making process and how they did that. But a lot of this really comes down to the discussion between the patient and their primary care provider, because that's where this generally happens. So females can definitely get it, and I think a lot of females do. If there's any history of an aneurysm in the family, the smoking doesn't have as big of an impact on that prevalence as it does in men.
Okay. Well, I think that's it for our questions. Dr. Larson and Dr. Newton, it was such a pleasure having both of you for this educational webinar, on aortic aneurysm and aortic dissection. Today, you provided valuable information on how VCU Health prevents, diagnoses, and corrects these silent life-threatening conditions. To learn more about Dr. Larson and Dr. Newton, as well as VCU Health Poly Heart Center, please visit vcuhealth.org. And to stay connected, please follow our social pages at VCU Health Heart and VCU Health. Once again, thank you to Dr. Larson and Dr. Newton, and all who joined today. Have a wonderful evening. Thank you so much.
Thanks so much.
Thank you very much.